In this video, we'll be talking about prolapsed intervertebral disc. So first, let's start with the relevant anatomy. It consists of three vertebral components, the intervertebral disc. So in the center, you have the nucleus pulposus, which is a remnant of the notochord. Then surrounding it, you have the annulus fibrosus. So that is the intervertebral disc proper. But between the vertebral body and the intervertebral disc, you have something called the end plate. So the cartilaginous end plate, it is a thin layer of hyaline cartilage between adjacent vertebral bodies and the disc proper. So the disc receives its nutrition from the vertebral bodies via these end plates, that is through diffusion. So the nucleus pulposus is a gelatinous material which lies a little posterior to the central axis of the vertebrae. This is the central axis, so it lies a little posterior to it. So the nucleus, so it is enclosed in the annulus fibrosus, which is composed of concentric rings of fibrocartilaginous tissue. The nucleus pulposus, you need to remember one thing, it is normally under positive pressure. It is restrained by the crucible-like annulus, okay? So the posterior longitudinal ligament also, it tries to keep the nucleus pulposus in place. It is a strap-like ligament at the back of the vertebral bodies and the discs. So the term prolapsed disc means the protrusion or extrusion of the nucleus fibrosus through a rent in the annulus fibrosus. Okay, so it is a protrusion or extrusion of the nucleus pulposus through a rent in the annulus fibrosus. That is the definition. It is not a one-time phenomenon. It is a sequence of changes in the disc which ultimately lead to prolapse. So what are the changes? First, you have something called the nucleus degeneration. So there is degeneration of the nucleus pulposus. So what happens is there is eventual softening and fragmentation of the nucleus, and then there is weakening and disintegration of the posterior part of the annulus. There is softening and fragmentation of the nucleus, and then degeneration and weakening of the posterior part of the annulus. Okay. So then what happens is it is followed by nucleus displacement. So the nucleus is under positive pressure at all times. So when the annulus becomes weak, either because of spontaneous disintegration and weakening, or because of injury, the nucleus pulposus tends to bulge through the defect. This is called disc protrusion. So see here you can see the nucleus, it tends to protrude out. Okay, it's a stage of protrusion right now. It's just a bulge. This tendency is greatly increased if the nucleus is degenerated and fragmented. Finally, the nucleus comes out of the annulus. It comes out of the annulus and just lies underneath the posterior longitudinal ligament. Though it has not lost contact with the parent disc. See, it is still in contact with the parent disc, okay? And it lies just underneath the posterior ligament, longitudinal ligament. This is called disc extrusion. So first there is protrusion and then there is disc extrusion. It lies underneath and it still hasn't lost contact. Okay, once extruded, the disc does not go back. The posterior longitudinal ligament, it is not strong enough to prevent the nucleus from protruding further. So the extruded disc may lose its contact with the parent disc. So then it is sequestrated. So first there is a stage of protrusion. It is just a bulge. Okay. And then there's a stage of extrusion where it extrudes out of the annulus fibrosus and lies beneath the posterior longitudinal ligament. And then there is a stage of sequestration when it goes out and there is no contact with the intervertebral disc. Okay, so the sequestrated disc may come to lie behind the posterior longitudinal ligament, or it may float freely in the canal. Then there is a stage of fibrosis. It is a stage of repair. This begins alongside degeneration. The residual nucleus pulposus, it becomes fibrosed. The extruded pulposus becomes flattened, and again it also gets fibrosed and undergoes calcification. At the same time, new bone formation occurs at the points where the posterior longitudinal ligament has been stripped from the vertebral body and there is a bony spur that forms. Okay, because the posterior longitudinal ligament also is stripped, the bone thinks that there is nothing keeping us in contact and there's a bony spur that forms. So the site of the exit of the nucleus is usually posterior lateral on one or the other side. Occasionally it is posterior, that is central in the posterior midline. So the type of nuclear protrusion may be a protrusion, an extrusion, or a sequestration. If it is just a bulge, it is protrusion. If it is still in contact and lies beneath the posterior longitudinal ligament, it is extrusion. If it is not in contact anymore, it is sequestration. So a dissecting extrusion, which is an extrusion with disc material between the body of the vertebra and the posterior longitudinal ligament. So there is stripping of the posterior longitudinal ligament from the body. So this may occur, that is dissection. The most common level of disc prolapse is between L4, L5, most common in the lumbar spine, and C5, C6 in the cervical spine, 4, 5, 5, 6, okay. In lumbar spine, it is uncommon above L3, L4 level. So what are the secondary changes associated with disc prolapse? See, first there are changes in the structures occupying the spinal canal. So basically, the unilateral protrusion is in contact with the spinal theca and it compresses one or more roots in their extrathecal course. Usually a single root is affected, single spinal nerve root. Sometimes two roots on the same or opposite side are affected. So what is affected is basically the one which leaves the spinal canal just below the next vertebra. This is because the root at the level of the prolapsed disc leaves in the upper half of the foramen. So that is why the nerve root affected in a disc prolapse is one that is exiting through the lower segment. So if there is a disc prolapse between L4 L5, then the affected nerve root is L5. Next, you can have pressure effects on the intrathecal roots of the cauda equina, which may occur because of a sudden large disc protrusion in the spinal canal. It may present as cauda equina syndrome. Then you can have changes in the intervertebral joints. So with the loss of a part of the nucleus pulposus and its subsequent fibrosis, the height of the disc is reduced. This affects the articulation of the posterior facet joints, and then again this can cause degenerative arthritis. So diagnosis is mainly clinical, but again you can use CT and MRI to confirm the diagnosis. Then clinical features, see, you need to remember two things in clinical features. There will be low back pain and sciatic pain. Okay, so the most common presenting symptom is low back pain with or without pain radiating down the back of the leg, okay, which is sciatica. So low backache. The onset may be acute or chronic. So an acute backache is severe with the spine held rigid by muscle spasm and any movement at the spine is painful. The patient may be able to go about with difficulty. So he'll walk with difficulty, but in extreme cases, he is completely incapacitated and any attempted movement produces severe pain and spasm. In chronic backache, the pain is dull, aching and diffuse, and it is worsened by exertion, forward bending, sitting or standing. So basically, when there is a postural variation, then the dull chronic pain is aggravated. It is relieved by rest. In sciatic pain, it is usually associated with low back pains, but sometimes it may be the sole presenting symptom. So it radiates to the gluteal region, the back of the thigh and the leg. So the pattern of radiation depends on the root compressed. So in S1 root compression, the pain radiates to the posterior lateral calf and the heel. So this happens in S1, posterior lateral calf and the heel. And in L5 root compression, the pain radiates to the anterolateral aspect of the leg and ankle. So L4 like this, anterior aspect. So L5, sorry, anterior aspect of the leg and the ankle. Okay, L5, S1, L5 anterior lateral, S1 posterior lateral. Next, in a disc prolapse at the higher level, such as L2, L3, etc., it may radiate to the front of the thigh. Okay. So often the radiation may begin on walking and is relieved on rest. It is neurological claudication. So then you can also have neurological symptoms. So paresthesia is most often described as pin and needle sensation. So it corresponds to the dermatome of the affected nerve root. So there may be numbness in the leg or foot and weakness of the muscles. In cases with large disc material compressing the theca and the roots, you can have a cauda equina syndrome. So there is irregular element type paralysis in the lower limbs, bilaterally absent ankle jerks, hypoesthesia in L5 to S4 dermatomes, and urinary and bowel incontinence. So examination, see, first talking about the posture. The patient stands with the rigid, flattened lumbar spine as if he's putting pressure on the on the hips. Okay, the trunk is tilted to one side, so there's a sciatic tilt or scoliosis, which is more on bending forwards. Okay, so the sideways tilt tends to exaggerate on attempted bending forwards. Okay, he is rigid and flattened lumbar spine. Okay, and the trunk is shifted forward on the hips. Next, movements. The patient is unable to bend forwards. Any such attempt initiates severe muscle spasm in the paraspinal muscles. Tenderness. There is diffuse tenderness in the lumbosacral region. Okay, so pain and tenderness. Posture is fixed like this, is drooping onto the hips, and there's a sciatic tilt as well. Then basically what what are the tests you do? So you can do an SLRT, which is straight leg raising test, which indicates nerve root compression. So positive SLRT at 40 degrees or less is suggestive of root compression. More important is a positive contralateral SLRT. Then you can do something called a Lasaghi test. So it is a modification of SLRT where first the hip is lifted to 90 degrees with the knee bent. Then the hip is lifted with the knee still bent, and then the knees, you try to extend the knee. If the nerve stretch is present, it will not be possible to do so, and the patient will experience pain in the back of the leg or the thigh. Then you proceed with the neurological examination. So motor weakness, sensory loss, or loss of reflexes, especially because the muscles of the foot, they're supplied by L4, L5 and S1 roots. And one important thing you need to remember is that the extensor hallucis longus muscle is exclusively supplied by the L5 root, and weakness is easily detected by asking the patient to dorsiflex the big toe against resistance. Okay, apply resistance and try to dorsiflex the big toe. Okay, so sensory loss may merely be the blunting of sensation or hypoesthesia in the dermatome of the affected root. So basically L5S1, so again the next one is affected, right? So S1 root is affected. So S1, there will be weakness of plantar flexors of the foot. So sensory loss over the lateral side of the foot. Okay, if like this. Okay, so this is S1. Okay, weakness of plantar flexors of the root. Okay, then reflexes, angle jerk is sluggish or absent. Next, L4, L5. So again, what is affected? L5. L5, we talked about this, extensor hallucis longus, so weakness. And again, it is a part of dorsiflexion, right? So there's a weakness of other dorsiflexors of the foot as well. So sensory loss over the dorsum of the foot and the lateral side of the leg. And then ankle jerk is normal, okay? Then L3, L4, what is affected? The next one, so L4. So weakness of extensors of the knee. So there is sensory loss over the great toe and the medial side of the leg. So medially it is L4 for medial. Okay, so knee jerk is sluggish or absent. Moving on to the investigation, so plain X-ray. It does not show any positive signs in a case of acute disc prolapse. So X-ray you do basically to rule out any bony pathology such as an infection. So in case of chronic prolapse, the affected disc space will be narrowed and there can be lipping of the vertebral margins posteriorly. But the investigation of choice remains the MRI scan. So normally in an axial cut section, the posterior border of a disc, it appears concave. See, like this. Okay, the posterior border is concave, but where there is disc prolapse, it will appear flat or convex as well because of extrusion or sequestration. The sagittal section upward and downward displacement of the prolapsed disc can be made out. Then CT scan, where you can't have MRI, you will do CT. You can see the herniated disc material within the spinal canal. Then you can also do an EMG, electromyography, especially to localize the distribution of the denervation to a particular nerve root. Okay, so to localize the offending disc, especially when there are multiple disc prolapses, but you rarely do it. And differential diagnosis, so it is a common cause of low backache, right? So other diseases that may mimic this include ankylosing spondylitis, vascular insufficiency, and especially in the spinal canal, sometimes in the stage of sequestration you are having a free floating mass, right? So tumors, like extradural tumors can mimic that, and spinal TB also can mimic that. So treatment, the principles of treatment, the aim is to achieve remission of symptoms, and mostly it is possible by conservative means. So for 3 to 6 weeks you try conservatively, and if it is still not being managed, or if the patient presents with cauda equina syndrome, then you have to go for an operation. So rest is the most important thing in the treatment of a prolapsed disc. So rest on a hard bed is necessary, but not for more than 2 to 4 days. And again, you give analgesics and muscle relaxants, and physiotherapy, hot fermentation, gentle exercises, etc. And others you can give lumbar traction and TENS, so transcutaneous electric nerve stimulation. So operative treatment, so especially when there is failure of conservative treatment, cauda equina syndrome if it is there, and severe sciatic tilt, you go for operation. So first what you'll do is you'll do a disc excision. That is the basic concept. You remove the prolapsed or extruded part of the disc by open surgery. So what all you can do first you can do a fenestration. So the ligamentum flavum is excised and the spinal canal is exposed. Okay, so ligamentum flavum, if you are excising it, that is fenestration. Along with excising the ligamentum flavum, so in addition to fenestration, If you make a hole in the lamina, that is laminotomy. If you remove the whole of the lamina on one side, that is hemilaminectomy, and on both sides if you remove it along with the spinous process, so that is total laminectomy or just simple laminectomy. You can also do an endoscopic discectomy. So this is a technique of disc excision where the disc is removed by using an endoscope. So you can use fine endoscopic instruments or laser probes. You insert it percutaneously through small stab wounds. It's a minimally invasive technique gaining popularity. You can also do a disc excision with spinal fusion. So where the spine is already unstable or it is likely to become unstable with time. So fusion of the affected segment is done at the same time as disc excision. So you fuse the affected segments to give some stability to the spine. Then you can also do something called a disc replacement. This is the latest technique. It is often offered as an alternative to traditional surgery of disc excision. Moving on to cervical disc prolapse. So it is much less common than in the lumbar spine, but C5, C6 is the one affected most in L4, L5, C5, C6. Okay. So posterior lateral protrusion is the most common again. So a typical patient, he presents with history of injury to the neck. Often it is a jerk or a twisting injury. So symptoms may begin hours after the episode of injury. The neck becomes stiff and the pain radiates to the shoulder or the outer aspect of the limb till the thumb. So paresthesias also may be felt in the hand. So on examination, it may be possible to localize a neurological deficit to a particular nerve root. Usually it is C5. So sometimes there may be signs of cord compression from the front, so UMN signs. X-rays, they don't show any abnormality. MRI again is the investigation of choice, but it should be done if operative intervention is contemplated. MRI must be done if you want to go for an operation. Most cases you do go for an operation. So there's a strong tendency to spontaneous recovery in case of cervical spine. So that is why when you're thinking of operation, you do MRI. Otherwise, you think it will recover spontaneously. So cases may present with signs of cord compression or root compression in the upper limb. Such cases may require surgery. So the disc is exposed from the front and the material is removed. Simultaneously, the affected segment is fused using bone graft and anterior plate.